Good afternoon. Thank you for joining us today. I am Dr. Melissa Bartik, and I'll be your moderator for today's discussion. I'm an assistant professor of medicine at Harvard Medical School and Mount Auburn Hospital, where I work as a hospitalist. As a researcher, I'm the principal investigator of the COVID Mother Study, which is an international survey of mothers looking at maternal and infant outcomes from COVID-19. I've authored some COVID-related articles for Harvard publications. We have just a few housekeeping details to share before we get started. I want to let you know that this program is being recorded today, and the link for the video will be available within a few days. The recording will be shared via email and will be posted to our website, and continuing education credits will be available. When today's webinar concludes, participants can click on the evaluation link in the description below this video window to obtain continuing education credits. So our guests today are Dr. Jeremy Faust and Dr. Joseph Allen. Dr. Allen is an assistant professor at the Harvard T.H. Chan School of Public Health and is an internationally renowned expert on the topic of healthy buildings. He directs the Healthy Buildings program at Harvard, and he is the co-author of Schools for Health, Risk Reduction Strategies for Reopening Schools, a publication of the Harvard Healthy Buildings program. Dr. Allen has been a leading voice in the response to COVID-19. He is an expert member of the Lancet Commission for COVID-19 and has been advising CEOs across major sectors of the economy, including healthcare, academia, finance, media, manufacturing, courts, prisons, shelters, and the arts. He has published more than 10 op-eds in leading newspapers with work featured in the New York Times, the Washington Post, USA Today, and the Financial Times. He is a co-author of Healthy Buildings, How Indoor Spaces Drive Performance and Productivity. His research is widely published in academic journals, and he serves as associate editor for the journals Indoor Air and the Journal of Exposure Science and Environmental Epidemiology. He earned his Doctor of Science from Boston University School of Public Health. And Dr. Jeremy Samuel Faust is a proud emergency physician at the Brigham and Women's Hospital in the Division of Health Policy and Public Health and is an instructor at Harvard Medical School. His writing about COVID has appeared in the Washington Post, The Atlantic, Scientific American, Newsweek, and Slate. His academic work on COVID has appeared in JAMA Internal Medicine, JAMA Network Open, the BMJ, and Clinical Infectious Diseases. He has appeared on CNN, CNBC, MSNBC, NBC, Fox, ABC's 2020, NPR, and others. He's the medical editor-in-chief of Brief 19, a blog of COVID-19 research and policy updates written by physicians, but for the general public. His primary hobby is serving as artistic director and conductor of the Longwood Chorus, an 80-voice ensemble of healthcare professionals and students dedicated to creating high-quality choral music in Boston. So let's get started with our panelists. So I want to ask both of you, first off, what is the evidence around how children are likely to transmit the virus and how likely they are to get sick? What do we know about this? Let's start with Jeremy. Jeremy, you're muted.
Great, good morning. Thanks for having me. It's good to see you again. And hearing that, I just thought, maybe we need a whole separate thing about Joe telling me when I can have my choir back, because that's all going to depend on the rooms. And singing is such an important part of my life, and kids too. So that's like part two. But let me jump in with sort of a little overview. I think people might be interested just to kind of review where we're at with pediatrics, with kids, both young and school age. And one thing that I think we know is a lot of, in terms of the number of cases, really does depend on your detection strategy. We hear numbers that 2%, 5%, maybe even less in some cases of COVID cases are in the pediatric population, but a lot of that might be just a matter of who we're testing. By those lights, in Massachusetts, for example, we do by 0 to 19, it's about half to a third of the infection rate, which is not nothing, but it's a lot less. But things get a little more reassuring, thankfully, I think we've all realized, when you look at hospitalizations and deaths. So hospitalization rates among kids, both as numbers and also just per population, per capita, is very, very low in that age group. So it's a tenth of that, even a 40th, or in some cases less. So very few pediatric hospitalizations, but enough certainly in certain areas like New York, where we've seen things crop up like these inflammatory conditions, which we can talk about. And then in the deaths, of course, is very, very small. So I think if it weren't the case, we'd be having a very different conversation. What I just want to mention is that there's some things about kids that are really interesting in this condition. One is that obviously I think we all know, but it's worth repeating, that most kids have much milder disease. It seems like the children have sooner presentation of symptoms. So there's a little bit less of that huge window, which I think is such a huge problem in terms of transmission. And but we do know that when kids get sick, that small fraction that they get very sick. Because once they're hospitalized, their need for oxygen, their need for the ICU is just a bit higher. So we're learning a lot about the sort of almost the needle in the haystack. Of course, schools is the haystack. And the question is, what are we going to do with these needles, and what's the effect going to be, and how contagious are they? I can talk a little bit about contagion, but I just want to make sure that I stop and just ask you two if there's anything else you want to jump in about the epidemiology piece, and I can talk just for a second about spread and just a couple of the papers that have come out about that.
Yeah, so I'll add to that. So thanks. It's nice to be here with everybody. Thanks, Melissa and Jeremy. It's nice to be part of this over at the School of Public Health, to be brought into the medical school. It's really a time for these kind of merging of disciplines. We're all in the same boat, of course. So yeah, I think about it the same way, going into this. And recently, to me, there's these three really important questions. Do kids, are they less likely to get it than adults? That seems to be like, yes. Are they less likely to suffer from the severe consequences like adults? Largely speaking, the answer is yes. Thankfully, this virus hasn't spared us in many ways, but this is one, fortunately. And the third one is that outstanding question is, are they more likely or less likely to transmit it than adults? And there, for me, that's been the outstanding one that I've been trying to really keep tabs on. And my read of the science at this point is that certainly for the younger kids, the 0 to 9-year-olds, the evidence looks quite compelling that they are less likely to transmit. I think it gets a bit muddier in that 10 to 19-year-old. And I think, Jeremy, you raised a great point. A lot of this, our understanding has been at a time when schools have been closed. So, we're basing a lot on what's happened overseas, outside of the US context. And we don't really have a lot of evidence base on that transmissibility once schools are back open. So that's how I've been thinking about those kind of three big questions. Fortunately, I think two are well answered. And one, I think, is there's still some open debate about.
Okay.
Yeah, I just want to throw in on just one more thing on this, which is about the third question, which is the sort of contagion. And I mean, is this where you want to talk a little bit about that, Melissa, or should we hold off? Is this the...
Well, there was that South Korean study that showed that kids 10 and over are as infectious as adults. So I'm wondering the implications of that for schools. Does that mean that we should be concerned about schools being open for older children?
Yeah, I mean, I like to weigh in on that one. I've been looking at that study pretty carefully. It's a really important study, right? Anytime we have data on a lot of kids and transmissibility, but unfortunately, I think it generates some headlines that don't quite capture the data. And I'll just talk about it for a second here. If you look at the data presented in that study, they split it up into two groups: within home transmission and outside of the home. And largely, the headlines focused on half the data set. And that data set really could have generated a headline that said, kids that are 0 to 9 are 2 to 3 times less likely to transmit than adults. That's an important finding. The headline was 10 and 19-year-olds transmit the same as adults, but there was really something incongruent in that data when you look carefully. The 10 and 19-year-olds in that data set didn't look like the 0 to 9-year-olds and didn't look like the 20 to 29-year-olds. They were really an outlier, and they looked like the 70 to 79-year-olds. For me, it was a giant caution flag looking at the data set. You see something that doesn't quite make sense. And it's because of the methodology of the study, which had a really hard time determining who was the index case when they went back and retrospectively looked at who got the case first and who might have transmitted it. If you look at the other half of the table, the same table, it makes a lot more sense. The 0 to 9-year-olds are less than adults. The 10 and 19-year-olds a little bit higher, but similar, similar to their age group and similar to the 20 to 29-year-olds. So I think if you look at the totality of evidence just in that one study, plus everything else we know, to me, it leads to my opinion at this point that the younger ages look like they transmit less. That middle group, I don't honestly believe that headline that says they're just, the 10 and 19-year-olds are just like adults. Well, certainly that South Korea study does not support that conclusion in totality. There's lots of methodological concerns about that study, and the data are incongruent even within this own study. So it's enough to say, let's pump the brakes on that one before we draw a major conclusion on 10 to 19-year-olds.
Yeah, and I would also just throw in that there's some, I mean, it's worth saying that there's been a sort of politicization of this topic, that kids are walled, that they can't spit it, that they're almost completely immune was the words I believe were used yesterday or something close to that. And we have to, I think, address that squarely on the head, which is, as you say, it's not true. Excuse me. But what is true is that, as you say, there's a lot of compelling evidence that the younger the kids are, the less they're probably going to transmit. And and as I mentioned before, some of that could be related to who you're testing, but some of it's not, and some of it's biological. And there's always you want to mix together the biological plus and the biological plausibility is nothing without the on-the-ground evidence. So I'll say if you had to choose one, go with what you're observing in real life. But in this case, they go together. And in the case of, we have emerging evidence. Why do kids seem to get this less? Why do they spread it less? So there's a really nice paper out of New York from a month or two ago. I'm sure it was a week ago, but it feels like a month ago, how time dilates. But that looked at the ACE2 receptors on cells. This is how the virus gets into cells. And what they saw was, not necessarily in COVID cases, they just had a bank of kids' cells from years and years back. And what they find is the older you get, the more ACE2 receptors you have, and in a very kind of predictable statistical way. And since we know that that's how the virus gets in, it kind of says, oh, well, if kids have fewer of those, then that's a good sign that this observation that we're having is real. And the same thing is true of obesity, by the way. People with obesity have more of these receptors. Another thing we're seeing more recent data is just the amount of viral genetic material that we're detecting in kids. And now that's not a complete 100% synonymous with contagion. It sounds like it, like, oh, higher viral levels. That sounds like it's more contagious. But in fact, these are viral particles that burst or broken down. And then that's how we actually detect it. We actually detect this viral nucleic acid, this genomic material, RNA, not necessarily as part of a full particle. It's actually when it's broken down. So it could be a sign that we're just destructing those particles. But in the kids, we are seeing in that very young age group far less, lower quantity, or put it this way, there's less of it, so that to make the chemical reaction work that we use, it takes more of that stuff of a kid's sample. So the more you have to get in order to find the sample, then the less genetic material you have. So it all tells a story, which I think kind of is that kids are not immune to this, but they're certainly less susceptible to it, and the epidemiologic data on top of it is telling that story. The question is, when you have so many kids, right? This is the old thing, a huge number, like the number of kids in the United States, multiplied by a tiny percentage, 0.001, is a pretty large number, right? You multiply 1 billion by 1%, and you're at 10 million. So you're in trouble, right? So that's I think where we're headed.
So that's a concern, because we know that there have been kids who've gotten seriously ill with COVID. There have been deaths of school-age children with COVID. And there have been deaths already of teachers with COVID. And if we reopen schools, it's probably a matter of time before we will see seriously ill children with COVID, or possibly deaths of children with COVID, or serious illnesses of children with COVID, or deaths of teachers or staff with COVID. So how do we think about this risk of opening schools? We know that school is important for children. I don't think anybody has any doubt about all the reasons why that is important, but how do we think about the risk? Because that risk is real and it's there, and it's not realistic to think that there's not going to be any serious cases of COVID among children, and certainly among adults as a result.
Yeah, so I'll jump in on that, and I think you hit it, Melissa, exactly right. And your question is that answer, a lot of it, that you know, there will be cases, and it's the exact reason Jeremy said, when you multiply these relatively lower risks against a lot of people, there will be cases. There's no such thing. There's no such thing as zero risk in anything we do, and certainly not during a pandemic. And I like to think, my background is in exposure and risk science, but we need to take a big look at exposure and risk. And we often tend to drill down into the in-classroom risk and isolate that risk question from the broader conversation of risk, as you nicely pointed out, Melissa, that we all know the risks of not being in school in person, right? Virtual dropouts, where we are in Boston, 10,000 high school kids didn't log in May. We've seen statistics out of Philadelphia, only half of the elementary school kids check in on any given day. This is back in May.
Wow.
We know it's 30 million plus kids rely on schools for food. We know kids are more sedentary when they're home. There's no socialization. UNICEF says they're at greater risk for abuse, exploitation, violence, and neglect. And so that's the bigger question here, right? So clearly, I think we're all on the same page that ideally kids are back in school, and we need to prioritize this. And as a country, we have opted for reopening other aspects of the economy ahead of prioritizing our kids getting back. So this is the bigger conversation of risk. Now, we also know there will be cases. There absolutely will be cases. Some of them will be severe. Unfortunately, any one death of a child or a teacher is a tragedy, and nothing short of that. So what we need to do is put in these risk reduction strategies. My team at Harvard put out a report on risk reduction strategies in schools, so that we can minimize that risk and drive it down as much as possible. Because to be really clear, we cannot go back to schools as usual. I don't think any of us are on this side saying, hey, you know what, just fling open the doors, everybody rush back in on day one. That's not going to work, because we know what has to take place. And it's the combination of the controls that you all do in hospitals every day that are working, and the rest of the public is starting to follow: hand washing, mask wearing, distancing as best you can. But importantly, one that gets ignored are these healthy building strategies, like higher ventilation rates, better filtration, portable air cleaners, these kind of engineering controls that have to happen in schools. And if we pair up enough of those and we do them well, we know we can drive down risk. And that, now I'm talking about the in-classroom risk, and then balance that or weigh that against risks of keeping kids out of school. And of course, another condition precedent is controlling community spread, which is the first and foremost needs to happen. So anyway, that's how I think of this larger question of risk in the context of schools.
Yeah, I think that's exactly right. And the headlines are we talked about this the other day, that there's going to be a headline saying that this kid in this school or this teacher got sick or had to go to the hospital or died. That headline is coming every week for the rest of the year. And it's going to be there on the front page of the newspaper, regardless of how prevalent the disease is, because there's enough cases that it'll be there. So the presence of those headlines won't actually give us any information. It'll just make everyone kind of panic. And what I foresee is happening is basically you already have kind of a sort of triage of situations. You have places who aren't going to open because either the risk is considered to be too high, or just the public has no appetite for it and they just don't want to do it. So major cities are seeing jurisdictions all over the country. The largest jurisdictions are not already going to remote learning. Then there's the ones who I think are going to try. And what's interesting there is, I think it's going to just be, we could sit here and say what's an acceptable number, but I think it's going to be the law of the jungle. It's going to be people's perception, which leads as to whether, is this a one-off? Is this actually a bellwether for something important? And I think that's really going to depend on community spread. It's not necessarily going to be, how many tests in the schools are you doing? I think it's going to reflect the community at large. I couldn't, when we were talking about our kids and our education and how important it is for them and how many dropouts there were, it made me think about this whole thing that we always talk about, how American kids are getting behind. We're not ahead on math compared to this country or that country, or our reading levels, or are we competitive? And it seems to me that those are all, small, they were important, but they were small kind of gradations. Now we're going to cede 6 months to a year of education to the rest of the world. This is going to be, I predict this is going to actually have a bigger impact than any tweaking we might have done in the negative direction. So it's I say this not to be like all doom and gloom, but to say that if we decide that this is the most important thing to control, that this virus is more important, the sooner that sort of lapse ends. Because I think that there are just some kids who aren't going to learn very well at home, even if they are showing up, let alone the ones, as you mentioned, who aren't.
So at the same time, we have states where they're insisting on opening schools, and there's a very widespread community spread of the virus. 10–20% positivity rates of tests, and their governors are insisting on opening the schools. Even Dr. Deborah Birx is saying, at least privately, that we shouldn't be opening schools in those communities. Some of the guidelines are hedging on what the percentage positivity rate should be to open schools. I've read 5%. I've also it just seems vague. But in a lot of places where there's pressure to open schools, certainly the test positivity rates are way higher than 5%. So what do you think the criteria should be for opening schools? What do you think about the states that are opening schools with very widespread virus and high test positivity rates? What criteria should we be using?
Yeah, I'll jump in. I think that, again, the more important thing is, again, the community, what's happening in the community, because the schools are a microcosm for that. The way I tend to think about this question of risk is to think about just literally risk. What is the literal risk? I don't think people actually know that. So for example, if you live in a very crowded city or highly dense area, and there are a certain number of cases, there are actually really good online risk calculators that will say, okay, in your city, there are this many cases, and if you're in a room with 50 people or with 100 people or 25 people or 10 people, here's your risk of being exposed. And then if you have that exposure 100 times, what's your risk of having been exposed? And then you can start to think, well, okay, if they do mitigation, things like masks, and there's really good hand washing. So the way I think about this question is to look at risk calculators for the community, because if the community is in very poor shape, than the schools are. So you can literally go, there's a wonderful calculator that a team at Georgia Tech has come up with, and it's just basic math, but it's just beautifully done, where you can answer that question. If you're in a room in Atlanta, Georgia with 100 people or 50 people, what's the odds of someone in that room having it? And if you get in the double digits and you're not doing anything about it, not only do I think you shouldn't open, those headlines are going to crop up quickly and it won't last. So that's my major way of thinking about it. I think that there are some other really important issues around equity and access that I think we need to talk about. I'll just throw that out there as a sort of starting point, but I'll let you guys sort of respond and I'll chime in as well.
Yeah, on the metrics, I think it's a good question. I mentioned the conditions precedent. I think there are two conditions precedent. One is the when to open, and that's based on community spread. And the second one is what needs to be done, what needs to be happening in the school. So it's the when and the what. And on the when, the community spread, a resource that I helped with came out of Harvard led by Danielle Allen at the Saffrow Center for Ethics, Ashish Jha at the Harvard Global Health Institute, which puts out some metrics that we could track and different risk levels and what could happen. So for example, the main metric is daily new cases per 100,000 people. And it's a probability question here. So if you're over 25 daily new cases per 100,000, we call that the red. That should be mandating everybody home. Now, if you tie that to recent outbreaks like the one in Georgia, it all makes sense. So Georgia had 37, at the time they had that outbreak in school, they had 37 new cases per 100,000. So they're well over the metric we're saying, it's kind of predictable if you have that level of community spread. And then if you read the details of the outbreak, it tells you that they weren't even doing the what to do correct. Meaning, I read their plan in the school. It talks about disinfection, great. It says masks, okay. The teachers, if you read what the teachers were saying, they weren't wearing their masks. And two, the plan doesn't mention ventilation at all. So, if you're going to have a high level of community spread and you're going to reopen schools at that point, it becomes a numbers game. Someone's likely to be sick in that group. Then you put them in a box, a room, and don't ventilate. and nobody's wearing masks, well, the probabilities are that they're going to get sick. In fact, there are calculators that add on to what the one Jeremy was saying. In my field of indoor air and risk assessment, there are calculators that will let you estimate your actual absolute risk with time spent indoors, with or without masks, under different ventilation rates. So you can combine those two calculators and say, what's the likelihood someone's going to be in the room? Then if they're talking loudly or singing, Jeremy, sorry, and emitting a lot of aerosol, what's your absolute risk? You put those together, and if you're at, like Georgia was, high community spread, no ventilation, no masks, yeah, it's not surprising we're going to see that exact headline, and we're going to see that over and over every time those conditions precedent are not met. Community spread under control and risk reduction strategies put in schools.
And this reminds me of a famous quote from a professional boxer, which is, everyone has a plan until they get punched in the face. And what I think you're talking about is there could be a lot of punches. And so then what do we do? And so I'm sitting here just thinking about this issue. And that's what interesting thing about these calls is these meetings is they make they make us think too. And okay, so I've gotten calls, now not as many as you have, Joe, but I've gotten calls from schools saying, hey, what should we do? And I usually say, I have no idea, in terms of when the rubber meets the road, because each, not because I'm punting, but because each jurisdiction has a different challenge. Is it the busing? Is it the space? And the one I really worry about is the adults who teach. So if you have 5 teachers out simply because they would be what the CDC at one point would have called a PUI, a person under investigation. In other words, they can't come to school because they've been exposed. It's too soon to know if they've got the virus. How many substitute teachers do you have lined up? Where are the kids going to go? If 5 teachers are out and it all ends up being nothing, it ends up being just a rhinovirus or adenovirus, something that's not harmful at all, well, fine. But then all the kids' parents are saying, I'm not sending my kids to school because 5 of the teachers are out. And then in hindsight, they said, well, that wasn't necessary. So the real issue I see is that we're worrying correctly. I'm not saying we shouldn't worry about the testing questions and the mitigation questions, but also I think that we're not thinking about the plan B, plan C, plan D, because it kind of feels like people are saying, well, if we can't open, we'll modify a little. If we can't do that, forget it. And to me, I think the one thing we have is creativity and time. We still have resources. So I'd like to start to see a more robust conversation about what are we going to do when these punches come, because they're coming. And I think it would be sad to just throw our hands up and say, you know what, forget it. It's too complicated, send them home, because there are so many reasons we've already discussed why that's really a detriment.
So Joe, you had said in your plans about making schools safe that all of these plans require kids to wear masks, no matter how good your building infrastructure is and what you do about the air quality. Kids still have to wear masks, staff still has to wear masks. Can you talk about that a little bit, and how we get kids to wear masks and how that's going to work?
Yeah, and this comes from the infectious disease modeling. My own team, we rebuilt the cruise ship outbreak because it's a perfect experiment. It's totally controlled. We know where everyone was. We know what day cases happened on. We know the time course, and we could rebuild that model and then use that model and apply it to any other indoor environment. A couple other groups have taken similar approaches. And anytime you play with these risk models, including our own, you can get really good risk reduction from these engineering controls. In fact, I want to talk about portable air cleaners with HEPA filters. Talk about something that can be done right now for relatively cheap in every classroom. A portable air cleaner can give you several air changes per hour of clean air. Let's put that aside for a second, because if you think about how to control those risks, the engineering controls are going to help. The hand washing is going to help a little. And when you model it all together, the only way to really drive down that risk is universal mask wearing. And it makes sense, right? At least in my space of the modeling, right, you have emissions and sinks or removal. And so the removal side is ventilation and dilution or air cleaning, and the emissions you can't control unless people are sick and they stay home, but then the asymptomatic period. And so you need something to control the emissions of the release into the space. It does a couple things. One, acts as a filter, obviously. 2, it slows the speed at which air comes out of the mouth. That's also critically important. And then it provides some benefit to the person on the other side. And even masks that are not as efficient as an N95, say 60% efficiency, but it has to go through 2 masks of 60%, that's 84%. That's pretty good. And then if you have the engineering controls in place, now you're really talking about a holistic risk reduction strategy that can drive down risk. But really, you can't get there all the way without masks, because duration factors into this too, right? If you're in the room for many, many hours and someone is sick and shedding a high viral load, then masks are going to be their key.
So
Joe,
how
I'm
do
curious.
kids
Oh,
wear masks?
I'm sorry.
How do we get kids to wear masks?
That goes beyond my expertise, other than as a parent of 3 kids. And so what are we doing? A colleague at Harvard, Julia Kayyem, says, we shouldn't be thinking of. She tells a story yesterday. We were on a webinar. She says, a friend of mine says, "Hey, I have a mask," and Julia says, "You have a mask? I have like 20 at this point. Like, you should treat them like socks." I think it's really a smart way to do it. And so same thing with my kids, right? We're trying different masks. What's most comfortable? What's cool? What color do they like? To make it like socks. And so that they start wearing it, they start getting used to it. So that's an anecdote. I'm not a behavior change specialist with children, but as a parent with my own kids, it's about reinforcing that, finding what works for them, what doesn't work for them, what style they like, what feels good over the ear and what doesn't. And then getting them used to it. I mean, this is our reality for many, many months coming up.
So you talked about things like having some classes outdoors, having recess time, having some quiet time where they're reading, and maybe they can have some mask breaks throughout the day, things like that. So they're not, they have some opportunities where they don't have to wear the mask constantly.
Yeah, well, you all know best. Sorry about mask fatigue, right? And I think it's real for kids. If they're outside, it's a great time to get the mask. First, we should be having classes outside as much as possible. You take the ventilation question right out of it, and that's a nice time. You can pull down the mask, keep kids separate. I also think if mask compliance is really challenging, which it could be, which it probably will be, in the classroom, masks can come off for short durations during quiet reading time, no talking. Right? It's not ideal, but if that leads to better compliance the rest of the time, I think it's a fair trade-off. And the risk calculus is that when you're talking or breathing hard or doing anything active, you're emitting a lot more. So if it's, a 10-minute quiet time, mask break, everyone pull out a book, absolutely no talking. If that helps kids wear masks the rest of the time, I'd be for it.
I think that kids have a pretty good BS detector. They're good at that, and they know how to, especially in the adolescence, they're testing their boundaries as well. I think that one thing that we're seeing a lot of right now is a kind of shaming around people who aren't 100% adherent to whatever recommendation we're making. So I understand, I sort of get involved with it too. It's like the mask doesn't work if it's not covering your nose, doesn't work when it's around your neck, but there's some degree of sort of like finger, no. And I think that in a way that can be very harmful, that kind of approach. It sort of puts it us versus you. Here's the good behavior, here's the bad behavior, and then you're gonna have the rebellious, streak of people is not gonna work. It backfires most of the time. There's certainly alarm fatigue. So if we treat everything the same way. So I actually think that you see headlines where they say, oh, people are out in bars and beaches. Well, wait a second, those aren't the same thing. Beaches are probably just fine as long as you can avoid the public restroom. Bars are a real disaster because of all of how tight everyone is, and they're making poor decisions because of alcohol, whatever else. So I think that one of the best ways we can get kids to wear masks is to, first of all, to be realistic. And so I agree that breaks are important. And I think that basically I'm imagining like the sort of like, parochial school in the 1950s that's very strict, this sort of like this cliche, right? That's not going to work because it's going to backfire. So I think that some degree of having a wider sort of, okay, we're doing our best, we're trying in these situations. Now here's a situation where it's no joking around. Everyone's got to have their masks on right now. So I think that we have to train our teachers and our administrators to basically not treat everything like it's a red alert. It sort of reminds me again, after 9/11, we were always on code orange, and they finally got rid of the color system because we were always on code orange. It was nothing else. So the same thing is true here. I think that if we just absolutely 100% lean in on this, it won't work. The thing that does work is telling people how they're helping. Okay, let's do this so we don't get anybody hurt. Okay, here's something where we don't need a mask. Here's something where we do. I think when people understand that we're trying to work with them, not against them, especially with kids, they're much more likely to go with something.
We had talked the other day about, having more classes outside, maybe having classes in tents, or even moving the school year so it's more in warmer months to facilitate having more time outdoors. So those things might possibly help. Certainly for places like Boston where we have more of a colder winter, that may be a problem. So
Yeah, I think we should be pushing for it. And even in Boston, the shoulder season now until November is be creative about how we can get outside and reimagine the classroom. And so I'll share a short acronym in a piece I had in the Washington Post last week that, at least for me, helps think about these other quick strategies, right? It's school smart. So the first is stay home when sick. I think that's pretty obvious. That goes a long way. Mask up for the M. A, air cleaner in every classroom. R, refresh the indoor air. That talks about ventilation. And T is exactly what you're talking about, Melissa. It's temporary classroom. If you can put tents outside, I know some communities are already doing that. I think that's a great idea. I tend to, have as much classroom time as you can outside. I look at what we did at healthcare, what you all did at healthcare, and we got real creative, right? Jacob Javits Convention Center was a hospital. There were tents in Central Park, talking about New York City context. Well, why can't we have classrooms in convention centers in every city? Why don't we take up all the available space we can, get kids out in parks, reimagine what is a school and what is a classroom? These are really unprecedented times. And so we need to be creative. It can't just be, hey, we're going to walk in the door and everyone's thinking the old way, right? You walk in, all these choke points. Well, let's change it drastically. Let's blow up the model and say, you know what? Class today's meeting at the park. That's class. And you know what? It's going to be cold. Everyone's got to wear a hat. It's just got to be really, really different. And it's time for some real, and it's going to vary, of course, by, where your school is, what kind of resources you have, what the area around your school is like. But it's time to get real creative. And even in a building, you don't need your auditorium anymore. So turn that into a classroom. Same thing with the gymnasium. My kid's school, the gymnasium is a physics classroom, which sounds perfect for that, right? It made this giant place just for a small little class. So yeah.
I'd be curious to hear what an economist would say about what some of these things would cost, but I actually have spoken to some economists about this. And every time I ask any question, what would it cost to do this? It's never come close to being nothing that anyone's proposing has become close to prohibitively expensive when you think of the opportunity lost of not doing it. So for example, you mentioned the Jacob Javits Center, or we had Operation Hope, places where, the Hope Hospital, places where we can, Boston Hope, excuse me. Places where we can isolate people that weren't ever meant for that. These are expensive endeavors, which save tons of money. Why? Because they controlled cases, because they got people the care they needed. If you don't do these things, if you don't put in the filters you're talking about, or build tents, or figure out how much does it cost, are we going to get a month more of school simply by heat lamps on the field? Like that is expensive, but it's so much cheaper than childcare because the parent can't go to work. So much cheaper than the economic loss and the developmental loss to our kids of having to miss a month of school. Some of these things I'd like to say they're a little bit expensive to think outside the box, to reimagine, as you say, what school is going to look like. But they pale in comparison to the expense, both in the human life and the cost of human lives, and also, quite frankly, in economics. So you look at the Congressional Budget Office, even in like May or June, they were saying this thing already cost us $15 trillion in productivity over 10 years. And that was before what just happened in the past 2 months. It is not going to be pretty. We're going to lose a couple of years worth of economic productivity because of our failure to address the virus. Ironically, because we're so concerned about the economy, we're opening sooner. And then that's going to create this huge second problem economically. I'm not an economist, but I speak to economists. So, but the reason I make this point is to say that everything that you're suggesting, and I think that Melissa is adding as well, in terms of like how expensive would it be to change the time of school and a year of school to get the unions involved. All that sounds very expensive, but I've yet to do a back of the envelope calculation with any economist who said, no, that wouldn't be worth it. That'd be money well spent.
Mm-hmm. So this leads to another question, which is that of equity. So, unfortunately, the populations that are most at risk for getting the virus are also tend to be the least equipped to be able to do remote learning at home, least able to have computers or internet access, high-speed internet access, people most likely to be essential workers and need to go to work, can't stay home to watch their kids. Um, you know, we need some creative solutions to help those families. One suggestion that I read about was having supervised online learning centers where families could drop their kids off at some large center that has computers and high-speed access, perhaps could provide free meals for kids who, you know, or normally would be getting them at school. We still have the same issues with contagion and infection risks there, but I don't know the best way to address this equity issue, and it's a very, very important one. But this whole virus has exposed many different issues about equity in terms of healthcare access, but now equity in education and educational access. What thoughts do you all have about that and how we can address this issue?
Sure, I'll jump in. And again, another question that I think was a really terrific answer, Melissa, where laid out the scope, and we've seen what this virus is doing. It's exposing the weakness and the systemic weaknesses across our society. And that extends to schools, of course. And if you look at the data on schools and school infrastructure, you see something like ventilation. On ventilation alone, 90% of schools don't even meet the minimum standard. It's not even a standard that's set for infection control. It's a minimum standard. Very few schools even meet this. And where is it worst? It's in disproportionately impacts communities of color and low-income communities. I mean, this is not surprising at this point. It's shocking still, but we know this, and it's because we've underinvested in our infrastructure, and disproportionately so. And it's one of the things in the schools conversation that has been quite frustrating to me, as we talk about all these things, and we're interviewing experts and teachers and administrators and superintendents. There are missing voices in this schools conversation. They're missing because they're missing. I've had teachers reach out to me and say, I'm concerned, and a low-income community says, I haven't heard from my students since March. I'm concerned if we don't get back in September, no one will have heard from these students for what, 8 months or a year? That makes you curl up when you hear that, right? Unaccounted for. Parents, essential workers, who's with these kids during the day? And it speaks to the larger, I think the biggest issue here is we have not prioritized getting kids back in school. What does that say about us as a society? It is not a surprise we'd be in August thinking about schools. When we close them in March, it should have been a national priority to say, whoa, how are we going to get kids back? Let's do everything we can. Instead, we're doing this piecemeal state-by-state approach, open up this, open up casinos, and kids are being left behind. These are the stories that are missing from the conversation right now. The cases will be headlines for sure, but these devastating costs of school closures will be the future 10 years of public health research stories that say, do you know what we lost this year of kids? Because they're not in the news stories. They're missing from this conversation entirely. And when we find them, when you hear about these consequences, it's hard to hear as a public health person how we're not prioritizing the schools question first and foremost.
But how do we fix that now? What do we do about it? With these supervised online learning centers, is that something that's viable? Is that something we could do? Or are there other kinds of solutions? What can we do now this late in the game?
I would say I have two ideas, and I'm here from Jeremy and you, Melissa, too. But one is if we step back to control the when and the what, right? The when, we step back our reopening until we open schools and can do them safely. Then we can think about other sectors of the economy. That's first. Two, we need we're spending trillions of dollars in stimulus. We bailed out many industries. To this question of Jeremy and The Economist, I did a back of the envelope on this air cleaner thing, right? Costs about $1 billion to get one in every classroom. 4 or 5 air changes per hour of clean air. That sounds like a lot of money. It's a fraction of what we've been spending. And imagine somebody says, well, here, we can help to get kids back to school. We step back our phases to prioritize kids back to school. And we make these improvements, not saying, hey, everyone's got to spend $1 million and fix the air handling system on their roof, which is going to take time. Let's drop some of these things in there, deploy masks, deploy these, portable air cleaners, and step back our phases. Could get us there really quickly. Really, it can be done.
So we close the bars and restaurants and nightclubs and casinos, work on schools and put in these portable air cleaners and mandate masks, and then we could sort of do it and hopefully bring a more equitable change to everything and get some of these essential workers back to work. And that would be a way to work on this. That
Yeah,
makes
and I
a lot
think
of sense to me.
Yeah.
I think that one of the biggest things hearing both of you guys talk about this is maybe we're asking the wrong question in a lot of ways. We say, I mean, and I think the when is a super important question, but I think that what happens when I think we need to change the when by changing what we're asking people. So, for example, my question wouldn't be what date should we reopen? My question should be, how long should we stay open? How long can schools stay open? What is your goal for school to open today and then or do you want to stay open for months at a time? If your goal is to stay open so the question is, how long do you want school to stay in session? That's the question. And once you say, oh, well, we're going to go to all this trouble and our goal is to see if we can keep schools open for 2 months at a time, do a little shutdown and then do another 2 months. Like, let's talk in terms of how long we can keep schools open. And then the when question, to your point, it becomes easier to answer because it says when we reach the metrics that tell us it's safe to do this, then we'll be able to open for 2 months at a time, because that's what matters is sort of number of kids in school times number of days in school. So, you know, people days in school. So that's number one. The second thing I would say is, and this really goes to the equity question, Melissa, is we can't know where to spend our resources if we don't have good data. And we unfortunately have seen in the beginning of this crisis, we were totally ill-equipped to follow this crisis in this country. It's wonderful that Johns Hopkins and the Atlantic and the other trackers have these things going. It is atrocious that the federal government had to outsource that essentially to the media and to schools of public health and all this kind of stuff. Why are we the only country that can't keep track? Now, the CDC did get back and they kind of caught up in terms of tracking hospitalizations. They were very, very wise to use the system they used to report like hospital-acquired infections. That was an incredibly smart idea that happened in lightning speed at the CDC, began to give us more data. They got pressure to give us demographic data, gender data, race, ethnicity, zip code data. The public really did a good job in saying we need more. The CDC responded to that. And what did the government do? They said, actually, you know what, we're going to take this away from you. And we're going to give it to our agency, HHS in DC, which is a much more political body. And all of a sudden, all that information is missing. And so if you want to know where to send resources, you're going to have another relief act coming through Congress. Right now, Congress is considering the 4th Relief Act. Well, there's appropriations for various kinds of things. It's like the census. The census is important, so we know where to spend our resources. Well, right now, because we're not getting good data, I guarantee you what's going to happen is we're going to, yet again, as it always happens, the people who already get discriminated against are going to be underrepresented in our data, and then there'll be less resources. So even if things that are relatively affordable aren't going to be diverted to the right area. So we need to absolutely insist on public data that is reliable and that is easy to access and that guides our responses. Because if we don't do that, it's all going to end up just helping the people who basically need the least help. I mean, we all need help, but let's face it, the haves and the have-nots are just going to get worse, and that's where this virus really kind of does its worst.
And you're talking about the private company that was given the contract to track the data that has some financial ties to the Trump administration.
Yeah, I mean, it's a short-term contract. I think that's
No
sort
big
of
contract. This
good to see, but
company, yeah, had a contract to track the data, and it's not transparent.
And they've been slower. I mean, that's the really interesting part, is that just for people who haven't kept up with this, is the CDC was doing a pretty good job of updating this information and expanding its portfolio of what they were reporting. And
it was transparent. And
correct.
Now it's not.
That's right. It's the updates are happening less frequently and it's harder to access.
Right. What do you guys think about colleges? So there's been Boston's a big college town. There's a lot of variation in what different colleges are doing. I've got 2 kids in college, and and one of them closed all their dorms and the other one didn't. And college kids are not necessarily reliable for social distancing and complying with recommendations. So I'm wondering what you guys think about the safety of colleges opening and having in-person classes and dorms and the like.
I'll jump in. Yeah, it's a challenging environment for those reasons. I don't think that age group is, necessarily, it should be called out more than other age groups. I think there's plenty of people acting irresponsibly in all age groups at this point. But on campus, I really like the approach that some of the universities are taking, where the idea is, one, de-densify the campus. And so that's key. And that's key for a couple of reasons. One, it can help reduce transmission because you can de-densify the number of people in any indoor space, but it also helps with testing. And, there have been some outstanding scientists in Boston and elsewhere, of course, contributing to this, understanding what kind of testing needs to be in place, how often you need to do it, not as much to prevent cases. The cases are going to happen, especially what happens off campus in particular. The spread will happen, but it's how do you prevent this from becoming explosive, where then you have to shut down the university, send people home? You can't really do that. Do you have enough space to quarantine them? And it's kind of like Jeremy's comment with the K through 12 schools. It's not like, hey, okay, let's all open, but can you open and stay open is the key. And it's even more important for the college age group, because you can't just send them home, right? K through 12 school, if it closes, okay, the kids are right there. What happens if you have 10,000 kids on a campus from all over the country and
the world,
and then you send them back? You can't really do that. So the goal here is rapid testing, so you identify it doesn't become explosive, so that you can quarantine. You have enough space to quarantine those who are sick. So that's the big challenge, but it's both of those strategies I think are smart. And it seems like most universities are going to that, de-densification and an aggressive testing regimen.
Even on the college level, there's the equity question as well, because when a school like Harvard decided to shut down when it did, no one, I don't think, had done really an analysis of saying, okay, well, now we're going to send a bunch of 18 to 22-year-olds home. And some of them may come from families, may now have to live with their parents who are at an age risk factor that's much higher than the people they're interacting with. So it was that, I'm not saying that was the incorrect decision. I'm just saying I didn't get the sense that there was much of an analysis of saying, wait a minute, should everyone go home? Is it actually, even though it's kind of uncomfortable, should we stay here and de-densify, as you said? Because the last thing you want to do is send someone who would have been fine at school, at college, back home, where now they've got to, be exposed. They're going to be exposed to older people or vulnerable people. So it also depends on what kind of a college, what's the economic makeup of that university. And then to the testing question, this is extremely interesting, I think. You're going to be in a double whammy situation, actually, from a testing perspective, because in a very high prevalent area, it's going to be a disaster and it's not going to go well. Then the high prevalent areas actually kind of really mess up the low prevalent areas. And let me explain to you how. If the low prevalent areas are going to be also the areas where people are doing a lot of testing, they take it very seriously. And in low prevalent areas, and we don't have time for the math, but what I could tell you is when you have a very low prevalence of disease and doing a lot of testing, the most common thing you're going to find is false positives. And now people say, oh gosh, we're having a spike because of, again, the hotspots, or, oh my God, are we the next hotspot? So now, because you failed to control the virus in one place, the places that are testing that have controlled the virus are going to be in this constant crisis kind of mode of figuring out, wait, what does this mean? And so there's different reasons why you test. You test to get a kind of community assessment. You test to change behavior. So if you want to do like random testing of asymptomatic people, which is what Harlan Krumholtz and I argued in an op-ed, and others have made the same argument, we weren't the only ones to think of this. But if you sort of approach testing kind of the way pollsters do for elections, you can't just stand outside the grocery store. That's not a representative sample. You have to do a validated testing. You have to know, okay, we're getting a really good segment of the population. The numbers are going to have a plus or minus, and so you can use random testing, if it's scientifically done, to let you know what your risk is in the area, and that helps you interpret the next thing, which is individual testing, saying, okay, we're actually running tests of individuals and reporting the results to the people. Because if you kind of try to mix them, which is essentially what we're doing in this country right now, we're doing a combination of screening testing for epidemiological reasons, and we're doing sort of diagnostic testing to change behaviors. But without having figured out who should be in those pools, we end up with this result that doesn't actually help, which is how safe is your area. So I think schools need to design testing strategies that help, and they need to be very clear about what they're trying to accomplish. Because if it's just, okay, every time we detect a case, we report it, then we're gonna close very quickly.
And of course, all of that is dependent on being able to turn those test results around in a timely fashion, which we have not been able to do now in large parts of the country. So that's been another failure and another crisis that we're seeing. So testing now has been a real problem. We haven't been able to get test results in a fashion that's been really very useful to a lot of people. If it takes 10 days to get a result back, that's people can go around infecting other people in that time frame if they're not quarantining. So that's the problem. In the past week, I think the country's been very shaken by this report of the outbreak in the summer camp in Georgia, where 300 kids were reported to have gotten infected in a matter of days. I wonder if you guys can talk a bit about that in our last few minutes here. We just have another minute or so.
I'll say one quick thing. I think this is an area for Joe, but we saw this in the camp. We saw a couple of choirs, which is an area near and dear to my heart. And what I think we're going to see here is that this virus is very sporadically contagious, and we think of super spreaders, but it's more, I'm beginning to imagine this thing as a geyser. And it's that sometimes a patient who's infected isn't really shedding, and then other times they're just spraying like crazy. And it may be they spend most of the time not shedding like crazy, but when they do, these events crop up. So for every one of these camps, there's 5 or 10 that didn't have that, but over time, that risk just adds up. So I think that if it were constantly as contagious as that event appears to have been, as the choir event appears to have been in Washington, for example, then it would be a different story. We'd all have it by now. This tells me that we actually have an opportunity to detect these things before they happen, and take it from the 5% of cases or 1% of time to even a smaller number to prevent that. But I'll let Joe go from there.
Yeah, I chalk it up to, if we don't put in controls, then we should expect cases. And this is the camp I mentioned where if you look at the CDC's investigation, they say there was no ventilation at all. And so you have a lot of kids, high occupant density, time spent indoors, including overnight sleeping, no ventilation, no mask wearing, and in the camp case, indoor singing. So again, we shouldn't be surprised there are cases in that scenario. And if you I don't want to blame, but right, if you don't put in risk control strategies and someone's sick, you should expect additional cases. Similar to that choir outbreak, we've known for a long time that airborne transmission can happen. Going back to the choir thing, the thing that caught my eye most about that choir practice, that's where 60 people were there, 1 infector, 52 probable or confirmed, 2 deaths. The thing that caught my eye first, and I used to do forensic investigations of sick buildings, was that the choir practice happened in the evening. And what happens is almost every building after hours, 5, 6, 7 o'clock, the ventilation system shuts down. And so before we even had the investigation, to me, with that number of people, fomite transmission, unlikely that 52 out of 60 would get it. Close contact, yeah, maybe some, right? You're seeing, but you have a larger room and that number are getting infected. And that the air handling system was shut off at that time. Again, no mask wearing. That was before the mask thing. So again, it became quite clear. It was clear to me early on that airborne transmission was playing a role, and ventilation is playing a role. We've known this for a long time. And this case study after case study that show it, and we're still seeing it this week, right up to the Israeli schools. Same thing. No masks, no ventilation. You should expect cases if someone's sick in that space. We can't just operate our buildings the same way and assume we're going to be okay.
Okay. Well, thank you both very much for this really wonderful webinar. I really appreciate your being here, and thanks to our audience for joining us. We have to wrap it up now, but this has been a wonderful hour. As a closing reminder, attendees can gain continuing education credits for participating in today's session. And that is all for today. Thank you very much.
Thanks, Melissa. Thanks, Jeremy.